Well, good evening, everybody, and happy holidays. Thank you very much for joining us. We'd like to welcome you to Incorporating EdgePRO, Predictable Outcomes and Streamlined Workflow, Delivering Patient and Practice Value in Everyday Endo. Honored this evening to have Dr. Charles Maupin with us. Many of you know Dr. Maupin, but in case you don't, Dr. Maupin is from Lubbock, Texas. Did his doctorate in dental surgery from Baylor College of Dentistry. Following graduation, attended UCLA, where he received his specialist training in endodontics as chief resident as well. Continues his connection to UCLA, serving as part-time faculty. Dr. Maupin is a diplomat of the American Board of Endodontics. He is an active member of the AAE, the American Dental Association, Texas Dental Association, South Plains District Dental Society. He's also a founding member of the International Academy of Endodontics, has contributed a great deal in the field of endodontics and also in areas of passion of minimally invasive endodontics, and now especially really leading the way in how to incorporate erbium chromium YSGG in endodontics as a real utility tool in the advanced cleaning and disinfection for complex root canal systems. Also, with over thousands of cases, he's really worked through the tips and tricks, very easy technology to integrate. Tonight, we're going to take a little bit of a step back and talk a little bit higher level. Certainly he'll share many of some of the exciting cases and things he's doing with regards to this technology. We encourage you all to ask questions. We've been pretty routine in terms of our offering of these webinars. We're going to continue that into 2024, balancing kind of high-level philosophy on why to incorporate a technology like EdgePRO into practice with more practical tips and tricks and training as you incorporate the technology. At the end of the webinar, I will introduce a unique program that we have to partner with Dr. Maupin in some advanced training should you decide to move forward between now and the end of the year with EdgePRO, and it's a very unique training opportunity that we will discuss. But again, there is a questions tab. Please ask any and all questions. We'll collate those at the end of the presentation with Dr. Maupin and make sure to get those answered. I'd like to now pass it over to Dr. Maupin. Again, we welcome everybody. Charles, thank you for joining us as well.
Hey, thanks for the intro, Chris. Again, happy holidays to everyone. Reiterate what Chris said here and look forward to jumping in here. I decided to shorten the title a little bit from the longer one here, just kind of incorporating the EdgePRO for everyday endodontics. And that's what I want to kind of focus on today is just everyday cases, straightforward cases. A lot of times we go to these lectures, we see kind of cherry pick cases here. So I took some just off my schedule yesterday, then we'll see a couple videos. And like Chris said, I mean, the workflow that you get from the EdgePRO, it's seamless, it's easy to integrate. There's virtually no disruption to your clinical practice by incorporating it. So again, thanks Chris, Zach, for having me on today. And we'll jump in here and like Chris said, just kind of ask questions as we go. And, I think the first question that I want to look at it is why now? Why should we start incorporating active irrigation into our treatment philosophy? And I think this is probably one of the hottest topics in endo right now is activated irrigation. Everywhere I look, I see it. In fact, today I had in my mail a little flyer from Dentsply, and they were talking about active irrigation and showed some SEMs, and they've got a new endo activator out. And so I think it's everywhere around us. And so it's, where do we look? How do we know what to look for? And kind of in preparing for this, came across this article here. This was in the November JOE, and it looked at the cleaning efficiency of different irrigation techniques in simulated severely curved complex root canal systems. And what they did, they took 3D printed teeth, and they had the root canal dimensions of 2506 shape in there. And with these 3D printed teeth, they had lateral canals at 2, 5, and 8 millimeters in all directions, not just one coming out, so all directions. And they fabricated this ABM, or artificial biofilm matrix hydrogel, and they placed it into the canals. They allowed it to sit in there. And then after about 5 minutes is when they started. They had continuous irrigation, sideband needle, GP cone agitation, manual agitation. They had the traditional endo activator. They had the eddy, they had, which is sonic activation as well, the eddy, ultrasonic activation, and then they had laser activated irrigation. So they looked at all of these methods here, and what they wanted to see was which one removed the ABM, at the highest level. So we looked at the results here, and laser activated irrigation showed the greatest removal of the ABM. What they did was, after treatment, they took photographs under the microscope, and then based on the surface area of removal, that's how they determine the percent there of the canals there. So laser activated irrigation, about 90%. The next closest thing was the eddy, which was 65.5%, followed by ultrasonic activation. And then the needle irrigation, manual agitation, and the endo activator all performed equally and obtained the lowest values. So if we go to the paper here and we look at a few key things here, the main and lateral canals here, laser activated irrigation and the sonic activated irrigation with the eddy showed the significantly best removal of the biofilm from the main canal. At all three levels, laser activated irrigation removes significantly more ABM from the lateral canals than any other technique. Continue on here, laser activated irrigation showed the significantly greatest removal, followed by SAI, thus the null hypothesis rejected. Laser activated irrigation was the only technique that removed the ABM completely from the main canal. And so this excellent biofilm removal of the laser in curved canals, it corroborates the findings of recent study, which you can look up there from this paper. And moreover, the laser activated irrigation was by far the most efficient technique in the lateral canals at the apical level. Besides LAI, only SAI was able to remove about 13% ABM from the apical level. So it talks about efficiency of removing it from the lateral canals. I'm going to show you just the overall efficiency that you get incorporating the laser. And this is just a little chart that they had there showing how they all compared the percent removal, biofilm removal. So I thought that was a very, very fitting paper, timely paper that came out as we're all talking about activated irrigation. Why now? Why to start looking into this now? And so I want to back up here. This was a case here I treated in June of 2020. This was a special needs patient. A 30-year-old special needs patient came in needing several teeth. He had a 29 by 31 bridge and number 28 heavily decayed as well. You could see complex anatomy going on, deep pocketing there on number 29. So we broke this down into manageable procedures for the patient. We treated one tooth at a time. On 6/8, we saw him and we treated tooth number 28 using the laser single visit treatment. 7/1 had him back. We removed the bridge, cleaned the decay up, treated tooth number 29. Again, laser activated irrigation. July 16th came back and we completed with tooth number 31. So why am I showing you this? Well, fast forward to yesterday, this patient was back in my chair here. And so I was able to gain recalls of this case here. So this is showing upper left image is the pre-op tooth number 28, upper right, pre-op tooth 28, lower left, the 3-year recall of tooth number, a little over 3-year, tooth 28 and tooth number 28. We see complete osseous regeneration going on. Tooth number 29, these were all, again, all done in a single visit. You can see this, probe to the apex, complete loss on the distal half there. Tooth number 29, complete osseous regeneration, tooth restored, 3-year follow-up. Again, a coronal slice here showing complete osseous regeneration as well. And we got out of order here in my slides a little bit. So this is what he came in here for yesterday. So we ended up treating tooth number 20. We've got a few other teeth. We're breaking this down into small bites that the special needs patient can handle. We cleaned it out. This tooth on the CT, not shown here, but it had single canal bifurcated into 2 canals and then came back and joined there. Was able to instrument one and was not able to instrument the other, but we spent plenty of time with the EdgePRO activating it. I could not get a real good x-ray here. It's showing the split, but we can see it on the image on the right that we were able to retrofill the additional canal in there and create that loop there, have that one restored. And then we're going to jump on to number 19 next. So again, long-term recall showing that activated irrigation is important to cleaning out complex anatomy, but also the efficiency that we were able to complete that in. Another recall, this was just a case I completed actually today as well. Again, I want to talk about everyday endodontics today. That's what we're talking about. This was a 17-year-old male. Saw him started this case 2 months ago. First visit, we cleaned it out. Once we removed all the gutta percha, then we used the EdgePRO for laser enhanced disinfection. And at that point in time, we put a little intracanal medicament in there, closed it up, and he came back one more time. I changed the calcium hydroxide out at that point in time, lasered again, the second appointment again though, and then had him back today, finished, and took the post-op. And I mean, we can see all the osseous regeneration that's occurred in just 2 months time, a little over 2 months time from that. So pretty significant healing. We know kids, younger patients heal fast, but I thought this was just pretty incredible healing. I mean, it was completely blown out. The tooth was very mobile at that first appointment, completely tight today, physiologic mobility going on. Everyday endo, making the complex less complex. This patient, elderly lady, she was in her mid-70s, saw this case yesterday, and deep decay on the distal. Talked about extraction. She didn't want to extract it at all. And so what the laser allows me to do is, number one, manage this case in a less time. She's trying to stay open for me. We came back in here and performed a gingivectomy using the laser, remove that tissue, and then we do a little barrier back there, access laser activated irrigation after some instrumentation is cut, obturate the case, and followed up with her today. She was doing great, no pain. Another case from yesterday, everyday endo. This patient had endodontic treatment done a couple years ago. She presented significant pain, swelling, and completed this case yesterday. First visit, we cleaned everything out, activated with the laser, got some drainage going on. I'm going to show you an image of that later on a different case. And then we completed the case yesterday. She was asymptomatic. You can see we were able to recapture that little apical curvature, picked up a little accessory anatomy going on there. So I anticipate osseous regeneration and healing of this case going on as well. Again, this patient came in, she had this restorative done last week, came in yesterday. She said she had a miserable weekend. Was on the couch all weekend. No one has time to be on the couch, but particularly right now during this time of year. So hot IP case, open the tooth up, laser activated irrigation. I mean, this is all done very efficient time manner. So you can see some kind of long multiplanar curvatures going on there, and followed up with the patient. Again, patient reported doing significantly better at today's appointment as well. So again, as Chris said, any questions arise, feel free to ask as we go. This was the emergency case. Emergency cases can always throw us off. So one of the most stressful things I think in our profession is being able to accommodate those patients, not throwing our schedule off. But I saw this patient at the end of the day, and lateral incisor here, or number 24, sorry, central incisor, pretty calcified, you can see. So he had a history of trauma, and that case calcified up, pretty tall crown on there. Anyone knows that have accessed these cases, these can be very stressful, particularly, end of the day, you're tired from a long day going in there from traditional endo, but you have a minimal margin of safety, window here for access. These cases always start, and what I've learned from the laser is when they're calcified, but you can see a little one, drill down a little bit. The thought process is drill down, run the laser. It's going to remove the debris, and then you can go in there and check for a canal. If you don't feel anything, drill another millimeter or two, and then I run the laser again. And what often happens, as the arrow is pointing to, is it unroofs just part of the canal there that I can see. And so this was actually on the distal buccal kind of axial wall where I was accessing the case. Was able to see the canal, slipped a file into it, opened it up, and then we started working. And so I'd done a local anesthesia on this guy, and about while we were working here midway through, he just starts kind of rubbing, and he says, man, I'm in so much pain. He's like, this is how I started. So I gave him a little mental anesthesia there, blocked the mental on the left side, a little more local there, and helped a little bit, but he didn't report, he still kept kind of rubbing right here, saying it hurt kind of way back in here, and this is, hadn't changed. Was able to instrument, ran through my instrumentation, 1504, 2006 kind of alternated. It was pretty tight canals. Got to linked with the 1504, nothing, no drainage. Put the EdgePRO laser fiber in just on water only. Ran that. As soon as I did that, it just started flowing out of the tooth. And that minute, the patient felt 100% relief. And so we had some apical trephination, got some drainage going on. And then after we took the rubber dam off, he said, man, he's like, when that happened, he said he likened it to, we got a splinter in your finger and just a ton of pressure. You pull that out, relieves all the pressure. He's like, the pain was gone, instantly. And so, utilizing the laser on these cases, emergency cases that come in, it's able to go in there, clean it out, establish some drainage. I mean, that's a key component of oral surgery that we learned in dental school is, hey, if you can get drainage, then, I mean, that's one of the key components when they come in a lot of pain that you're going to relieve their pain there. So left this tooth open, and he's coming back tomorrow, and we'll close it up tomorrow. But, I know he's doing 100% better. Just everyday endo. This was the first patient of yesterday. Came in and had recent restorative done and crown preps done. And again, same story as that other lady. Miserable weekend, just been excruciating pain, popping the Advil, couldn't get the pain under control. This was first case from yesterday. And you can see how we were able to treat this tooth conservatively, respect the canal anatomy. I mean, we mimic the canal anatomy. Showing this to a friend here after we treated it, and he's like, you can see a lot of calcification going on in the palatal root, real wide palatal root here. And, the comment was, well, do you think maybe you just plug this with debris, and that's why you kind of got the apical bifurcation going on in the palatal root? Here's another post-op view. You can see separate MB1, MB2 canals, clean to the canal terminus, very conservative shapes. And I take a cone beam on every case. That way I know the anatomy going in. So I think it's pretty cool to look at the cone beam on the palatal canal. And this, number one, I had to remove all that calcification, and took a little bit of time, but we instrumented kind of beside it, and then we just ran the 200 micron. So this is why I think it's important to be able to go inside the canals. You put the 200 micron in there, and you'll just see these bits of calcified, pulp, this denticles just being flushed out from that. But you can see the canal comes down here, stays wide, and then we have that little snake tongue going on there. And I mean, we just replicated that, mimicked that canal anatomy perfectly. Again, follow up with the patient, doing well on this. So now he can follow up and get the crowns on there. So everyday endo, staying on time, efficient, and taking care of the patient population that we have. So my EdgePRO, my general guidelines are to incorporate the EdgePRO as early as possible into the procedure. And this is going to aid with removal of the organic debris, necrotic tissue, facilitate instrumentation, helps to minimize transportation of the debris apically. We know that one of the main causes of post-op pain is pushing this debris apically. So if we can minimize the amount of debris in there before we start instrumentation, there's less chance that we're going to auger and transport that apically. Utilize the EdgePRO in between file usage, remove that inorganic debris that accumulates from our file build up there, and that packs into the isthmuses, packs into the canal walls. Prevents just like I said, the inorganic debris accumulation, isthmuses, fins, tubules. So my guidelines here, tip number 2 and 3, utilize those in the chamber only. You can use this with solutions or water, solutions being hypochlorite, EDTA, solutions of your choice. That's what the 2 main ones that I use. The number 1 tip is used to mid-root only. This is my protocol. I take it to mid-root only, and I'll use this with solutions or water. I showed that calcification. I started that out with water only to flush everything out. Once I got it flushed out, then we switched to the solutions. Anterior teeth, like that small one I showed earlier, that you want to adjust your joules on that, your millijoules. So we don't want to have that as high on a lower anterior that we have set for a molar. So always adjust that. Vital teeth protocol. Instrument, what I like to do is remove the pulp tissue before I start any irrigation, particularly with hypochlorite there. But so instrument to a 1704 prior to introduction of the EdgePRO. Then you're going to come in and we're going to do what I call the coronal conditioning step using, I like the number 3. I stock the number 1 17 millimeter and then the number 3 10 millimeter. Those are the only 2 tips that I stock. Simplifies everything and I can do everything I need to with those. But 1 watt 50 hertz hypochlorite, air and water are turned off. Then you're going to continue your instrumentation. The EdgePRO allows you to be in control. You can shape to, that 2004, 2006 if you'd like, or if you want to go a little larger, you can go a little larger. Personally, for me, I like to stay on the small side. I think, we've seen the huge benefits of minimally invasive endodontics. And now that we have the active irrigation to complement that, everything is just starting to mesh and merge and come together there. The goal is to preserve our patient's teeth, and saving tooth structure is one of them, but also removing biofilm, pulp tissue, all that is the other key component of it. So we're going to go to the canal disinfection protocol, 0.75 to 1.25 watts, 50 hertz. Air and water's off, fiber taken to mid-root, and you activate on your way out only. Then we're going to follow that up with a final rinse. I like to do 2 watts, 20 hertz with water, 90% air off. Necrotic protocol, it's very similar to the vital, except with the necrotic, we're starting in with the immediately after access, before any instrumentation is done. We come in here and we do 2 watts, 20 hertz water just to flush everything out like we talked about earlier. Then we're going to instrument the canals. Then we go back to, just like the vital protocol, the canal disinfection, 0.75 to 1.25. Assistant can fill the chamber with solutions, or you can fill, and you always have to have some type of solution in the tooth. So never, make sure the tooth is full with either water, hypochlorite, EDTA, your solution of choice. And then we come back and we do a final rinse as well. So we're going to look at a couple videos here just so you can see the workflow. Again, we're talking everyday endodontics, bread and butter type cases that you're seeing here. This was pre-op image on the left, and this is immediately after access decay removal first, obviously, and then access, and you can see just the liquefactive necrosis going on. We're going to come in here, add a little cool dam as a barrier. We're going to come in with a laser just to clean everything out. So this is just water only. You see a big chunk of tissue come out right there. So that's everything that we don't want to push apically. So again, this is stuff that we don't want to push apically that causes a flare up. We're flushing this out first. This cavitational framing from the laser is forcing everything up and out of the canals, loosening it up, so we don't, again, pack it apically and cause a flare up. So we run that for about 45 seconds to a minute. Again, image on the left, this was right after access, decay removal access. Image on the right is before any instrumentation is done. And you can see we've got the canals cleaned out. Isthmus is already a little bit cleaned out. No instrumentation is done. No files have touched the tooth, no hypochlorite, no nothing. This is just laser water only on that image there. So now we can come in, get our instrumentation, and which we've done. And now we're going to come in here with our solution. So we'll start, again, just a little water here first, kind of flush everything out, but I've instrumented the case. Water only here going on. Now what I'm going to do is I'm going to come in here with the solutions. And so with this one, because it's a smaller tooth, smaller access to the area, I'm gonna fill the chamber canals myself rather than having a continuous flow. Molars, a lot of times I do a continuous flow. Have my assistant full solution. This one I'm gonna come in here and you're gonna see I'm gonna drop the bit root, then I'm gonna activate on the way out. And then when you reach the orifice level, you're going to hold for about 10 to 15, 20 seconds. So you just hold right there, continue that activation, let it kind of work, do its thing there. So we're at 1.25 watts, 50 hertz on here. Drop down the other canal, same thing. Mid root, activate on the way out. We're going to come back and we're going to refill the solutions again. Looking great, okay? And you can see the activation that's going on there, that fluid that just popped out. These canals join, so it's coming down one, going down the other, and popping out the other canal there. Coming back again with solution. Again, very important to always have irrigating solution inside the teeth as we do this. Activate on our way out. One more time. And you know, a general guideline is we say go in there, you know, 3 times fluoride, 3 times EDTA, and then I like to come back another time or two with hypo. But you're in control. If you think you need to do more, well, let's rinse out here, then we'll start putting the filler in, okay? By all means, go ahead and do it longer. If you have a tight canal, you feel like it's complicated anatomy, go ahead and do it more. So then we come back again with water one last time for the final flush out. And come in here in microsection and see both canals out there. Here's our images. Image on the left is after instrumentation and running the laser again. You can see it really opened up the isthmus in between here. This was just after laser alone. So you can see how clean everything is there. Obturation, 2 canals joined. We've got a couple lateral canals coming off, a couple fiber posts. We've done a gingivectomy there with the laser, so it made restorative piece of cake when the time came to restore the case there. Another a tooth here that we're going to look at a little quick video. Deep decay, you can see the pre-op here. Gross decay, that hypertrophic tissue is really overgrown there. So came in here, laser gingivectomy, cool dam, isolation is where we're going to pick this case up. All right. So I wanted to show you here, I removed the stock from my files. This, again, it's all about efficiency in there. My assistant is rinsing my file off as I pull out, removing all the debris from the flute. I've got the line on the file that I use for my link, so I can go in and out of each canal without having to stop and take measurements there. So that's how we do our instrumentation. Again, the whole key point of instrumentation now is to just create a fluid pathway. That way we can get in there as fast as possible with the active irrigation, with the laser activated irrigation. That's what does the cleaning and disinfection, not the instrumentation. Activating and holding at the top, 10 seconds. When the disc will come out right there. Open real big for me. You know, we're in the MB there, and I want you to notice on this one, we got some heat coming out, things we got in the canal on the MB. You'll see why that is here in just a minute. Dropping down the MB, mid root, activate, hold on the way out. Right at the work, about 10 seconds. Coming back in here with hypochlorite again. See how much cleaner each and every pass, everything just continues to look cleaner and cleaner. We'll drop it back down there in the MB again, activate. No heme coming now, so there was a little resorptive defect in there full of tissue. Help flush that tissue out of there. On that first pass coming there, now we activate, hold, and things up it back down again now. And hold, And we just go through the disinfection process. Again, very straightforward. Laser sits right off to my side. I grab it. I'm able to toggle back and forth in between it. Files. Just no disruption to the flow of the defense there. And here's the post-op. You can see from the gingivectomy, laser gingivectomy, made restorative walk in the park. Came in here, operated the case. Little accessory canal there. We see that resorptive defect that we flushed out as well there. CT, you can see off the axial slice, the lateral, the kind of lateral canal there in the apical portion. Same right there coming off. So, a lot of the questions are, well, before I jump in, before I make this purchase, I need to talk about the ROI. And, I think now we're at a point I can understand, when we're looking at these units, 120,000, 100,000, that makes it a little, more challenging. You really need to look into that. But when we're looking at the EdgePRO unit, I can tell you part of the ROI stuff that we need to look at is you have an elevated level of confidence for treatment or in your treatment. What do I mean by that is, your routine cases become more routine. Your complex cases become less complex. And this all allows you to develop this efficiency once you get systems in place there. And so you have an increase in efficiency. And I would say roughly, my experience in talking with other clinicians as well, it makes you about 20 to 30% faster. And so let's just take a 75-minute treatment on average. That's going to save you, cut your 75-minute down to, 60 minutes, maybe a little under 60 minutes. So you're saving 15 to 20 minutes per case. 4 cases in the morning, 3 cases in the morning, you're talking about an hour that you can save. So you're looking at, if you do 3 in the morning, 3 in the afternoon, 2 hours that you save over that time period. You can do a couple things with that, add in another treatment per day, 2 treatments, save those for emergency time slots. That's what I do at the end of the day. We're able to work cases in like that central incisor that we showed, that patient can't afford to wait another day. Other days you finish early, and it impacts your quality of life. So scheduling efficiencies allows your front office more flexibility in scheduling. One of the best things to grow your endo practice is availability. I think we all know that is being available. Hey, they call up, patient pain, send them over. We'll take care of it, from there. I think that's one of the most impactful things to your ROI is availability, but having the confidence that send them over, you can take care of it from there. And so it's hard for each person is going to be completely different on, how is this going to increase my EBITDA, my profits, my bottom line. Like I said, a practice that's traditional 2 visit may see a little more of a bump as you go to a single visit. I traditionally was that. Single visit practice, you're going to be taking on a little more complex cases like that number 29 I showed earlier. Complete blowout there. I think most of us probably are treating those in multi-visit early on. I'm pretty comfortable treating those single visit. I do a combo intracanal and kind of a perio treatment as well, using the laser on those. So we're doing inside the tooth and outside the tooth as well. Seeing great results doing that as well. So, as we talk about making the routine more routine, show this number 14 here, recent case, just mesial occlusal decay, came in here and, it makes the endo a breeze. And what that does is that allows you more time to focus on the restorative. And so we're not rushing at the very end, and then you kind of end up with, this restores okay. It's not my favorite. Got a great contour here, used BioClear matrix on this one. Great restorative contour here. And the endo, again, like I said, was the easy part, set me up for success at the end. I wasn't tired, I wasn't fatigued at the end. I was able to complete the restorative all. These are 1-hour cases. Another one, more routine, came in here, cleaned out the decay, did a laser gingivectomy here. Again, that made at the very end, I'm not fighting all that going in there. Doing the gingivectomy, scrubbing viscostat, creating a bloody mess, trying to clean it up. It was ready to go. Once I finished the endo, pop off the cool dam, isolate, put a little matrix there, matrix of choice, and restore the case there. And then it takes the complex cases, makes them less complex. You know, and part of this is you got to have the right systems in place. Early on, these cases, I mean, they were exhausting. They're still challenging by any means, but two long visits, you know, you're cleaning up the decay first visit, trying to gain isolation on these that, you know, deep buccal decay there. And, you know, by the time you do all that, you're 45 minutes in, and then, you know, patient's tired, you're tired. So then it's a quick pulpectomy, medicate, temporary Fuji or something in there, and then they have them back. Well, then the tissue's kind of growing back next time. You got to re-go through all that. So 2 long appointments, but this one, clean the decay. We got it isolated, SG clamp there for isolation. Cleaned up the decay, then laser gingivectomy on the side, and that's what you're seeing here in this bottom right image. You can see we've got bone dry, complete isolation here going on. Cool dam now to isolate that. Then we come in with our laser for laser activated irrigation. Got some webbing here, a little mid-root there, a little accessory anatomy going on apically. Packed a little cord there at the very end just to aid with the buildup, and then we can see we've got a nice buildup going on. Cleaned it up, diamond there. Cases, this was all done in roughly an hour. So makes the routine more routine, the complex less complex when you have the systems. It requires systems in place as well as technology. You know, in this one, I think the microscope and laser EdgePRO crucial to be able to accomplish these in a single setting there. So with that, you know, I'll turn it over to Chris. Wish everyone a Merry Christmas and Happy New Year. And I'll turn that over to Chris. I'm open for any questions. You can also email me at any time. But Chris, I'll kick it back over to you.
Great. Thank you, Charles, for once again another very informative presentation. You know, Dr. Maupin makes himself very available. He's been excellent at really sharing his experiences. You saw some of the cases that he does, and every day I know those are cases from this week. So we saw what his week has looked like thus far, which is awesome. You know, he's also shared, you know, his tips and tricks. We go a layer deeper in some of the past webinars that you might or might not have been exposed to. Around his technique, around the protocols that he showed for vital and necrotic. All of that information is accessible and available. And Dr. Maupin, we thank you for always being willing to share that information. We incorporate a lot of it into our training as well. I'll talk a little bit about that after the questions here. But yeah, we have a few questions for you here, Charles, if I may. First one here, how do pre-patency laser-assisted irrigation and post-patency laser-assisted irrigation techniques differ?
You know, I don't know that there is a huge difference between the two. I'll tell you, I don't fight patency anymore. And in some prior lectures, I've talked about this. I've showed several cases here. You know, they'll say a palatal root, for instance, like that one I showed earlier. You know, early on, I may not be patent on that because it bifurcates and my file is just hitting dead center. And so we'll say it's 20 to that. My file stops at 18. Then what I do is I don't really spend time again pre-bents anymore. I'll instrument to 18. I run the laser several passes with that. I may go water only initially, and then I'll go back in, check it again with file. And if it goes to length, awesome. And I would say 75–80% of the time after I do that, it does go to length. And if it doesn't, that's okay as well. I'll just continue through it and work through it. I may put a little bin or two in there and try to find it, because we like to get that red line on the apex locator. Just makes the fill easier. But if I don't, that's okay. I'm comfortable obturating the case. The times that I don't obturate, and I talked about this in the MB2 lecture as well, as again, I always take a pre-op CT. If the MB2 is completely separate on the CT and I don't have that all the way down, I don't locate it, then that's the time I'll close up and have them back. Now, if the MB2 looks like it joins, I haven't found it, I spend a lot of extra time in the MB with the laser, the EdgePRO #1 tip. I'll put it halfway in or right at the orifice, a lot of time activating. I go ahead and complete those cases, and I've showed, again, on prior lectures, plenty of these MB2s where we retro-filled that MB2 from the MB1 canal. So again, post apical patency basically stays the same for me. I still take the tip I've talked about, mid-root. That's where I'm comfortable with solutions. I've been using it since 2018. Have not had any issues for me personally using any solutions with pre or post patency on that.
Excellent. Great, thank you. You mentioned ease of integration into workflow. Is there much for your staff to do to get it ready for you to use throughout the day?
No. So start of the day, they're going to prime the unit, make sure we empty, there's a water bottle, they're going to fill the water bottle with distilled water. They're going to put the handpiece on, turn the unit on, flip a switch, turn the key, prime the unit, then it's ready to go. And then at the end of the day, they're going to purge the unit, empty the water bottle, and shut the unit off. I mean, that is it. So if you're using it in between, you know, if you move it from op to op, then shut it down, you know, purge it, shut it down, take the handpiece off, you know, that one goes in autoclave, next one goes on, reprime it. I mean, it's up to go. And to prime it, it takes 10 seconds. You hit a button, primes, auto primes, you're ready to go. It's easy.
Excellent, thank you. How much do you charge if you charge extra for use of the EdgePRO?
I don't. It's incorporated in, just like cone beam. Everything is for me incorporated in there. I'm not saying that's right or wrong, but I think everyone needs to settle on what they're comfortable with. And I understand each practice is different. Insurance versus fee for service. Everyone is completely different on how you have to do that. And you do need to be compensated for adding in technology for your time. So I personally don't, but you know, if that needs to do that to fit in, I think you can. I think one of the benefits about the EdgePRO though is it's very cost effective, you know, unit to incorporate. And so I don't think you'd have to do much on that. But one of the ways also that you're developing that type of ROI is just the efficiencies that you're going to gain. And so you can make up for that, you know, with another case a day. Not saying you want to. Some of us, if you're already, you know, a lot of it's mentally exhausting what we do. You know, we're putting together 6, 7, 8 tough puzzles a day. So sometimes just even the thought of adding another case in, even if you're more efficient, you're like, hey, I'd rather go home, hang out with family or whatever. But one way you can, you know, make up for that cost is by adding a case in per day as well.
Great, thank you. Does the EdgePRO in the main canal achieve patency in a bifurcation canal, which the file wasn't able to enter?
Yes. So I showed that earlier, that tooth number 20. Let me see here. The answer is yes, it does. I've showed that several times. Lots of lectures here, but I'll just pop back to this one real quick. There it was. So can you see that, Chris?
Yep.
Okay. So you see right here, this is the main canal coming down. This was a 1 to 2 to 1, and we see I did not get a file in here. This was on the special needs patient. So he did really good, but you know, there's challenges on those. We all know. I mean, doing what we do, treating this case, you know, regularly is tough. But I just spent a lot of time with the laser in there, and we were able to get in that loop, that you know, lingual canal. And on the CT I took, I mean, it was one big one down, and I mean, it was way down that it split, and it would have been people much more skilled than I with hand files could do it. I'm thankful for this technology because that was one thing that I wasn't, you know, if anyone's familiar with Steve Delgado is a master with prevent hand files on doing those. That's the one thing that I was gifted with. So I'm thankful for this technology. Chris, thank you all for getting this where it helps me on cases like this. But right. Yes, it will treat those.
A couple more questions here, Charles. Beautiful cases. What are your settings for gingivectomy? Thank you, Dr. Barnett. Question from Dr. Fred Barnett. Glad he's on.
Yes. Let me see here. Settings for gingivectomy. So I tell you, I've got the EdgePRO, the settings would be 2 watts, 20 hertz, and you're gonna have your water probably 50%, air 20% or so. So I do minor gingivectomies with that. And I'm also using a diode a lot for gingivectomies now. Diode works a little different. It's kind of by heat. But I'll tell you, I've been speaking with Chris a little bit on this, very receptive, and I think their Edge is investigating this as well. But the diode is kind of like the icing on the cake for the EdgePRO as far as coming in and kind of helping out. But you got to have the EdgePRO first to do the cleaning and disinfection and kind of contouring there a little bit of some tissues. Then you come with a diode and it seals off any of the little bleeding vessels or anything. So, but if you're using just the EdgePRO 2 watt, 20 hertz.
Great, thank you. Do you intentionally instrument short now by approximately 1 millimeter or not worry about patency? Does this instrumenting short seem to decrease your post-op sensitivity or pain complaints? Does it impact / decrease the number of patients complaining of discomfort when tapping on the side of the tooth, post-treatment neuropathy, etc.?
I haven't changed my instrumentation protocol. So I still instrument 2 length with a 1504. And then vital cases, I have always, probably go back 10 years where I said on vital cases, I try to stay a millimeter short. On vital cases, I think those patients do better when you're not, disrupting the periodontium and inflaming it. So vital cases, I always stay a millimeter short. Necrotic cases, I take my 1504 through the apex. So 20, I'm okay taking it to 21 millimeters on necrotic cases. But I don't change anything.
Great. What type of sealer and obturation do you recommend?
My sealer of choice is Kerr. I'm comfortable using it. I've been using it from day one. It's been around forever. So that's what I use. And then obturation, I call it a warm modified. So, the smaller shapes, I'll down pack to maybe mid root. It gives me the warm and fuzzies. I guess probably don't have to, but that's my choice. I think there's a lot of people using the bioceramics now, and I played around with them a little bit, but I like that I can control the consistency of the Kerr. I like that it's got some, silver in it, which is antibacterial agent. So for me, that's what I use.
Excellent, thank you. Has EdgePRO assisted with any broken file removal?
Yeah, so thankfully I don't see many of those. I know there's some endodontists out there. They're had a good friend, and he's had a lot of success with it. And so I'm not speaking from experience really on this, but from talking with him, Dr. Zabari, is if the file is, we'll say, less than 4 millimeters, the separated instrument, that go in there and kind of bypass a little bit with the 810 hand file, and then go in there and run the laser protocol. He's had phenomenal success with removing it. If it's a longer segment where that file's still gonna bind against the tooth wall, no, not on that. But the small pieces, absolutely.
Great. How do you get the sealer to flow to the apex, or is it the apical half or part of the canal filled with gutta percha?
Back up real quick to the files. I was just thinking, if you're seeing a lot of broken files, it's probably a time to recommend the Edge file to your GPs as well, because that X7 does not break. It's a workhorse. It's one of my favorite. But the how do I get the sealer to the end? I'm not, since incorporating the laser, I don't change anything, but my technique is I coat the cone, I seed it to length, maybe 1 or 2 pumps. I take it out, I recoat it, I put it back in, and then I down pack System B, and then I use a fine plugger to about mid root, and that's, again, that's my technique. So nothing fancy. I don't squirt canals. I know a lot of people will do squirt technique. once they get smaller. I personally, occasionally I will do that, but I think you lack control with that. And so again, part of the incorporating the laser and everything is creating these efficiencies in your practice. And you squirt a case and you'll have, one out of, I don't know, a few cases that it ends up being way short. And then you set yourself back 30 minutes, 20, 30 minutes, because you got to go in there, remove the gutta percha, then you got to reclean it, and you're back at square one. So I like to, 95+% of my cases, make sure I've got that 15 or 20, 406 to length, and then a cone just easily goes.
Great. Some practical questions here. We have 3 ops and 1 doc. Can we get by with 1 unit? Does the unit take up too much space, especially with the ASI cart? Any ergonomic issues? A lot there.
A lot of questions there. So I would say you need more than 1 unit if you have 3 docs. I think each doctor needs a unit. You don't want to be, again, you're completely getting rid of the efficiency factor. If you're in a case and Dr. Smith over here is using the unit, and then you got to wait and use it. So,
I should clarify. It says 3 ops and 1 doc. Sorry.
Oh, 3 ops. Okay, maybe I misunderstood.
Yeah.
Okay, 3 ops and 1 doc. No, 3 ops and 1 doc. I mean, you can absolutely get by with 1 unit. So obviously, you're going to be moving it around a little bit, which again, we talked about earlier. It's super easy. Shut it down, unplug it, unhook the air, roll it. It's on a cart, roll it in, and put it in the other one. So I've got an ASI cart and the laser. And so my ASI cart is at my, 12 o'clock straight ahead, we're 12 o'clock, 6 o'clock straight ahead. It'd be at my, like say 8, 9 o'clock. And then my laser is over here at like 10 o'clock. And so all I do is I slide my SI cart over, slide it down and over once I'm done with the handpiece, and I pull the laser over, and then I grab that and I'm in with that. So no issues. Yeah, you should be fine with 1. I think after you start using 1, you're probably going to want to get another one though, just to create that, less moving around.
How are you marketing the device to referrals? How do you instill value for your patients?
As far as marketing, I've never done a, huge deal on sending out, hey, we've incorporated this. I think one of the best ways to market is just send back solid work, happy patients, one after the other. And second part of the question was,
how do you instill value for your patients?
I think that, so I was talking with a doc here recently, and we're talking about, giving breaks to certain people, or maybe this was chat online, and a staff member, from Dr. So-and-so, how should I handle that? And I think the best way to handle that is just knock the case out of the park, and that's discount enough. I mean, we spend a lot of time learning how to do this and how to do it at a high level, and so just provide high quality work. And every case go in there, sure, you're going to have some that, hey, I could have done that better, but I mean, by and large, every case, do it at a high level, do it well, and I mean, that's how you provide the value, and the patients will see that. I think, they go in and, we get compliments all the time just on how well I work with my assistants in the scope with me, how we pass instruments. If someone's in the room, they're like, wow, I've never seen, that dance like that before in instruments, and incorporating, the microscope, the laser, everything into it. And they're like, by the time they're 45 minutes in and finished, they're like, oh, that was so fast too. My last root canal took 2.5 hours.
Yeah. I think that's sage advice. I think that's great. Well, those are the questions. I just wanted to quickly wrap up here again. Dr. Maupin, thank you again for spending such a valuable time with us. Your presentations are always so insightful. To that end, Edge here, we're very committed to this space, as you all know, and we developed this system in concert with our partner BioLace, really designed around, trying to advance the field of advanced cleaning and disinfection and endodontics. And so EdgePRO is, feature rich with, what do you need to be able to achieve this? We've stripped out a lot of the features that you don't need, and in doing so, it's allowed us, as Dr. Maupin might have mentioned, to create a price point for the system that we think is reasonable, especially for what you all are doing as specialists. And so, as you know, the MSRP for the system is $35,000 per unit. The tips are $20 per tip, single use per case. And we are running some end of year specials, holiday promotions that your area sales managers can discuss with you should you be interested in looking to move forward fairly quickly between now and the end of the year. I will add to that Dr. Maupin's been very gracious to work with us around training and education. We've spent time within his practice. Helped to video some of these great cases he has. He has just an amazing library of cases that can go on and on and on. So it's hard to share over one webinar or even series of webinars that we've done with him this past 6 to 9 months. So we're going to continue with that. One unique offering is that if you look to commercialize and purchase a system between now and December 31st, we will go forward with our traditional use of using our team to install and train, provide the initial training on the system for you and your staff, make sure that your airlines are equipped to be able to accept EdgePRO, and make sure that that's all in place. We'll go through the basic training protocol with you all, and then be there chairside for you to go through your initial cases. Then following that, we're working with Dr. Maupin on a distance learning series of 2 webinars that will go through more of kind of what you saw this evening, even in greater detail and in more depth, not just around cases and how to approach it, cases for advanced cleaning and disinfection with EdgePRO, but some of the utility applications that we've talked about initially here as well. So he's a wealth of knowledge and has offered to provide that for us on a go forward as we look at engaging in advanced training. So for those that are looking to move forward between now and the end of the year, we're going to have you included in that group that will be able to take advantage of that distance learning series, which we will look to get everybody onboarded in the January, early February timeframe. So we would start that advanced series by the end of February to give people enough time to amass some semblance of experience, because then we think it's going to be more valuable for you, especially as you're coming to the discussion with some questions and an opportunity to engage. So that is something that we're offering here at Edge. And so if you're interested, I urge you to get in contact with your area sales manager, and they can discuss more in detail around the program. But I think that's going to be it for this evening. Thank you all. Again, thank you, Dr. Maupin, for once again sharing such an informative presentation. And we wish everybody a happy holiday season. Thanks so much. Have a good night. Take care.